Well, to continue with the remaining part of heart failure. Medical management of heart failure with normal ejection fraction. In contrast to heart failure with reduced ejection fraction, evidence is lacking for any specific therapy to reduce the mortality in patients with HF-NEF. In 2005, ACC-AHA, that is American College of Cardiology and American Heart Association guidelines do offer some recommendations for treatment of HAF, HF-NEF. Main therapeutic goals include avoid the tachycardia, avoid the ischemia, avoid hypertension. Medications recommendations. Beta-adrenergic antagonists and or calcium channel blockers have value in that they both develop or help reduce the heart rate, improve the diastolic filling time, decrease in blood pressure, decrease myocardial ischemia. ACE inhibitors, ARBs, in addition to decreasing the afterload, may help in the regression of myocardial fibrosis. Anesthetic implication of heart failure with normal ejection fraction. Pre-op, up to 61.5% of geriatric surgical patients exhibit evidence of abnormal diastolic filling. Patients must be medically optimized by addressing uncontrolled hypertension, atrial fibrillation, heart failure, or myocardial ischemia. Patients should continue their cardiac medications. Day of surgery and avoid the heart failure exacerbations. Intraoperative standard ASA monitors are usually all that is required for the patient with HF-NEF. The decision for invasive monitoring should be individual and take into account the anticipated surgical stress, anticipated volume shifts, and comorbidities. IV and inhalation anesthetic agents both can adversely affect the cardiac diastolic function. Maintaining the hemodynamic parameters seem to be more important than avoiding the certain anesthetic agents. In fact, diastolic function may actually improve after induction of general anesthesia. Avoid the tachycardia since it shortens the diastolic filling time. Blood pressure should be maintained within 10% of baseline since hypertension can impede the ejection, exacerbate the ischemia, and increase the left ventricular volume. Whereas hypotension, especially diastolic hypotension, can cause a decrease in coronary perfusion pressure, resulting in the ischemia. Avoid the hypercarbia and hypoxia, both of which may exacerbate any pre-existing pulmonary hypertension. Close management of volume status is mandatory since patients are very sensitive to alterations in the preload. Now, key point, the general or regional anesthetic induced venodilatation may decrease the venous return and preload. Caution is advised. However, in indiscriminately administering the fluid, because upon emergence, venous return is restored and this may precipitate the pulmonary edema or atrial fibrillation. Post-operative, patients with HF, NEF should be observed closely in the early post-operative period. Volume overload may not only occur, not only in the post-anesthesia care unit, but around the post-operative day 3 as any third space fluid is reabsorbed. Pain control important to limit tachycardia and hypertension. Now we come to the summary for anesthetic considerations for HF, REF and HF, NEF, preoperative. Optimization of hypertension, ischemia, heart failure, arrhythmias, continue the home medications, understand the clinical effects of concomitantly administered diuretic, vasodilator or inotrope and the interaction with anesthetic agents. Be aware of any pacemaker or defibrillator and plan accordingly. Intraoperative. Consider the invasive monitors if clinically indicated. Hemodynamic goals are more important than the choice of anesthetic technique. Avoid the tachycardia. HF, NEF. Avoid the avoid the hypertension or excessive hypotension. Post-operative, observe for volume overload and provide the adequate pain control. Now we come to the end of my lecture session. Hope you have enjoyed it. looking forward to meet you in the next session. Thank you.